Good afternoon and welcome to September's expert panel discussion. If you were with us last month, you know that we started out by talking about ARDS, a topic that is really super central to what we do in respiratory critical care. As you know, we only talk about respiratory critical care topics here. We want to tell you how much we appreciate you signing on and taking part in this discussion. And at the very end, we part of the way that we operate here is we don't rehearse, we don't do present a lot of data, a lot of slides. I am going to present a few slides just to recap what we talked about in part one. But then after that, we're kind of just going to go with the flow, and we're going to talk about things that we believe are important for everybody to discuss and to understand. So I will start out by saying that there is a chat box. If you can find that, then you can post questions or discussion. If you have something to say during the discussion, then just bring it up there, and we'll try to address that in a timely manner. And somebody's popcorn's done. And so we'll go ahead and introduce ourselves first. My name is Keith Lamb. I'm a respiratory therapist, and I practice in Charlottesville, Virginia. Hollywood.
My popcorn's done. I am John Ancrott, flight respiratory therapist at Advent Health in Orlando, Florida.
Eric.
Oh, I didn't hear you.
That's okay.
My name is Eric Kreiner. I am a respiratory therapist out of Washington, D.C.
Andy.
Good afternoon, everyone. Andy Klein. I'm a respiratory therapist from Chicago, Illinois.
And Joey. No microphone.
Muted, Joe.
Gets me every time. Joe Hilton, respiratory therapist, Charlotte, North Carolina.
It's a good thing that we don't all rely on the understanding of technology to do our jobs. So from there, we'll go ahead and get on started. The last slide that we'll show you eventually has a couple of links. Link to our website, link to our previous recordings of all the panel discussions that we've done prior to, and a link to my email address so that if you want to reach out to me with recommendations or anything that you want to discuss, you can do so. So today's discussion is Ask an Expert ARDS Part Two. We'll start out with a recap of ARDS definition. This is stuff that we talked about during Part One. And then once we're done with that, we'll move on to basic ventilator management, advanced management, and interventions. And we'll wrap up with what I'm sure will be an interesting discussion period. But like I said prior, you can reach out via the chat feature anytime that you want. So I'm going to go ahead and recap ARDS Part 1. And basically, we'll start out with the definition of ARDS. This was the most recent definition of ARDS, which seems like it was last week, but it was in fact 2012 when the Berlin definition was published. And basically, it just outlined the different criteria that a patient's severity of illness needed to meet in order to meet the requirement and the definition of the syndrome of acute respiratory distress. So it basically outlined that it had to be it was still divided up into three different severities of illness, but they got rid of the acute lung injury part, which was the mild ARDS replaced by mild ARDS. The illness had to be acute and persistent onset. There had to be radiologic evidence that demonstrated, and I'll show you what I think that looks like here in a moment. But there had to be radiologic evidence, and there had to be a hypoxemia. And it was divided. They divided the syndrome into three different levels of hypoxemia. Severe ARDS being a PF ratio less than 100, moderate at less than 300.
Hey, Keith, real quick, can you, I apologize. Can you go back real quick and just run through that briefly because you froze up?
Oh, okay. Yeah, sure. So the definition of ARDS was divided up and is given that the patient exhibited the other components of the syndrome, being radiologic evidence, had to be acute. Previous to this, it couldn't have any component of heart failure, which was sort of ambiguous, if you will, because I think that a lot of really sick patients have multiple etiologies, right? They also have some heart failure involved based on volume, resuscitation, et cetera. But the hypoxemia is divided into three different severities of illness. And for severe ARDS, it was a PF ratio of less than 100. Moderate ARDS, a PF ratio between 100 and 200. And mild ARDS, a PF ratio of greater than 200 and less than or equal to 300. Fast forward till just recently, last year, where the new global definition of ARDS was published. And I think this is kind of important because as a clinician and a part-time hobbyist researcher, if you will, the definition of ARDS may not be as helpful to the clinician, if you will. And I'm interested to hear what everyone else says. But may not be as interesting to clinicians as it is to researchers, because researchers can then take this controlled, if you will, definition and compare different patients to each other, right? And sort of sequester types of patients so that they can study the same sort of patients that have the same level of illness. So anyway, so fast forward to just last year, where the new ARDS definition criteria came out, and they added a couple of things. Now the patient didn't have to be intubated anymore. We all see these patients that are really sick that don't wind up getting intubated. We saw a lot of these patients in the pandemic, and high flow nasal cannula, which is a non-invasive intervention that is very popular and used across the board. Many patients that would have met the criteria of ARDS, but weren't intubated and were on high flow would not. Line or arterial access is not always available. People had researched the SF ratio and sort of, developed some data that showed that there's pretty good correlation, particularly in the middle, maybe not in the outliers, if you will, but there's a decent correlation between SF ratio, and it's sensitive enough for clinicians to sort of use that to look at patients and see how poor their oxygenation is. And one of the other big things was now, because POCUS, or point of care ultrasound, is now super popular and available more readily in ICUs. Instead of doing a chest X-ray, you could confirm these bilateral infiltrates, opacities via ultrasound instead of a chest X-ray. Also, in resource-limited countries or settings, the following were not required, and I can't see them because my little move the slide button is in the way. Can anybody read that last sentence for me?
PEEP, oxygen flow, or specific respiratory supporting devices.
Thank you, John.
Sure.
So primary ARD, there are two sort of bulk categories for ARDS. One would be primary, or something that started or originated in the chest or in the lungs. And the number one etiology of primary ARDS is pneumonia, but you can see the other ones there. Aspiration, pulmonary trauma contusions, drowning or near drowning, inhalational injuries, fat emboli, embry perfusion injury. And the other category is secondary ARDS. And when you look at the literature, you'll see that these are called different things depending upon who's who's writing or putting the data and literature together. Primary, secondary, pulmonary, extrapulmonary, et cetera. There's a couple of other ones too. But for this talk, we'll talk about secondary and primary. And for secondary ARDS, that just simply means that the insult occurred somewhere else, and then those inflammatory mediators circulated from that primary source, or that secondary source rather, and then wound up in the lungs where it caused an inflammatory process in the lungs. And the number one etiology of secondary ARDS is sepsis. We've all seen these in textbooks. I don't expect you to really be able to read any of this, but I do like to use this image because it sort of shows the complexity of the inflammatory cascade with the interleukins and all of the other sort of inflammatory mediators that are involved in this inflammatory process. Now, this is the same sort of inflammatory process, but it happens in the ankle. Let's say you step down off the curb and you get this swollen ankle. It's the same process. Difference being that this inflammatory process will not likely kill you, whereas this sort of exaggerated inflammatory process that happens in the lungs may. And in fact, it happens about 40% of the time. This is an image that shows the same patient with a multidimensional high-resolution CT scan image versus a chest X-ray. And you can see here that you can see this chest X-ray on a patient and say, I've seen worse, However, when you get a CT scan of that same patient that shows this multidimensional image, you realize that it's much more involved than and severe than you might have thought just by looking at that chest X-ray. This is an image I like to show. These are both 5'9" males, and we're going to talk about tidal volumes, plateau pressures. We have some of the people on this panel are certainly worldwide experts, and when you look up literature, you're going to see these people as co-authors on lots of different things. So we'll get much more into this. However, I just wanted to show you that not all ARDS is the same, right? Let's say that both of these are 5'9" males. And again, we're going to talk about tidal volume. But for now, let's say you wanted to use 6 milliliters per kilogram predicted body weight on both of these patients, then it would be 424 milliliters if you looked at the table. If you're fortunate enough, like we are, to have it in our EMR system, then you would use 424 milliliters on each of these patients. Clearly, that tidal volume would exhibit different levels of stress and strain and energy applied to the lungs in each of these patients. So I only show this slide to demonstrate that this is much more complicated than just using 6 cc's per kilogram predicted body weight on every patient. And finally, if you're familiar with the literature and you're familiar with the Lung Safe trial, many years after ARDSNet was published, no matter where you go in the world, if you go to Charlottesville, Washington, D.C., Chicago, North Carolina, no matter where you go, the mortality for moderate to severe ARDS is about 40%. And that's better than it was in the 70s. However, it's not really budged much in the last few years. So that's sort of what we talked about in ARDS Part 1. And so now we will sort of open it up to talk about these subtopics here. And I'll go ahead and just start off and then open it up. But start off with tidal volume. We know since the year 2000, when the ARMOR trial was published by the ARDSNet group, that lower tidal volumes demonstrated lower mortality. And so that is a very, very basic beginning in ventilator management of ARDS patients. Anybody want to take it from there?
Sure, I can jump in. Everybody's so anxious to talk.
Mhm.
Plateau pressure, again, coming from the 2000 paper that Keith mentioned from the ARDS study, which is 25 years old, folks. Think about that. It's 25 years old. And we're still running into occasionally some places that still don't follow it. The tidal volume and plateau pressure, they're hand in hand. All of these things that we're going to talk about go hand in hand. You can't do just one and claim yourself lung protective. You have to do all of them in conjunction. Because if you've been to one of Kreiner's talks and you talk about the equation of motion or mechanical power, all of these things in the end have a result on what's going on. Anybody want to take driving pressure and the rest of them? I'll stop there.
Yeah, I'll jump in, Joe. So as you mentioned, I think it's a great lead in. So all of these things sort of intermingle, right? So when we think about driving pressure, and I know there's other things that we call driving pressure, but for our purposes here, we're talking about the plateau pressure minus the PEEP. So you see all those things are represented on Keith's list here. So really what we think about here is our PEEP at a level where we have recruited everything we can recruit without over-distending? Is our tidal volume low enough to keep our plateau pressure in a respectable range? And then is the resulting difference between those two at a safe level? So we're looking at all those things together to get to driving pressure. So the tidal volume, the plateau pressure, the PEEP all factor into the driving pressure, along with obviously the lung compliance, which is probably pretty poor in these patients. And so our target, based on Dr. Amato, among others, work starting in the mid-2000s, is 15 centimeters of water pressure is what we're targeting. So what does this mean in terms of vent management? So in my world, and I'm happy to hear everybody else's opinion, in my world, the first thing you do is optimize your PEEP. You turn your PEEP up until you are no longer recruiting and before you start over distending, so that you find that optimal level of PEEP and optimal level of recruitment. Then you take a measurement. If your driving pressure is above 15, you start slowly walking down your tidal volume until you get into that safe range. And then you just keep monitoring and keep making adjustments as your mechanics change throughout the disease process. And I'll pause there and let somebody else talk.
Eric, does asynchrony come into play at all during the management of patients that have ARDS?
Yeah. I think it does. Well, I know it does for sure. I think if you want to lay out this entire patient, in terms of their clinical course and their context, I think that shifts throughout time, essentially. I really, really, really like Eduardo Morales', and their group's kind of, their slant on where they are in the time course context of patient management, and identifying straight out of the gate what is our therapeutic intention and goal of a particular patient right now today. Is it safety, is it comfort, or is it liberation, right? And so if you identify that, and let's say that the patient is newly intubated right at the very beginning of the course, you would clearly identify that patient as, yep, our main therapeutic intention is safety, right? And identifying all the ways that we can protect this patient against hurting themselves or protect ourselves from hurting them, right? All these mechanisms in ventilator-induced lung injury. And so if we're going to say at the beginning of this course, this patient's course, we're safety, let's say that is the case. Most of these patients are probably going to be well sedated and kind of put down at that point, so that they're not competing with care, low volumes, and having a high drive that is making them really tachypneic or really with a lot of effort, right? So at the beginning, in safety mode and safety intention, they're going to be well sedated. And so what you would think about, I guess, with patient ventilator interaction isn't the effort related interaction or the timing, the asynchronies of triggering and that sort of thing, right? I think what you're going to be really on the lookout for is the presence of like reverse triggering, or what would be an early trigger at the beginning portion. So if you're going to say asynchrony, there's different types, and they kind of show themselves in different parts of the patient's course. And so asynchrony very specifically in the beginning, when patients are heavily sedated, clearly isn't going to be, a certain grouping of them. It's going to be more this reverse triggering type of thing, right? So I think you need to be well aware of that form of asynchrony. And reverse triggering is, typically you can think about this in a couple different ways. A normal trigger is the patient makes the effort and then triggers the ventilator to deliver the breath. If it was in reverse, the ventilator delivers the breath in a mandatory form or by a time trigger, and it actually stimulates the patient to take a breath. So it's reversed in its interaction. That's where that wording reverse triggering comes from. You can think of it as an early trigger. The ventilator triggers before the patient actually makes the effort. And that interaction typically happens in deep sedation. So it would be showing up in this safety mode. And so that asynchrony, I think, is what you're going to look for there. All right. That's kind of the big one that's going to show itself there. As you progress from safety into comfort, then you're thinking about a whole different bucket of types of asynchrony, because now you're decreasing levels of sedation and introducing more patient interaction into that. But so I would say this, maybe Andy and you guys had started to talk about it, but I think you have this when you first start out, you have the rules, right? Like what are the boxes that you would check? I need a adequate PEEP, whatever that means, who knows, right? Moderate levels of PEEP to achieve an oxygenation surrogate, which I think is what a lot of people do, or you set it according to a table, an FiO2 table. We don't use tables here. I think we just titrate to an oxygen surrogate. It tends to drift along that table, but we don't have tables anymore. We've kind of graduated away from that. So we typically set a moderate level of PEEP anywhere from 10 to 15 in that ballpark. We'll set a 6 cc tidal volume, and we'll come back and assess the plateau and then the driving pressure. And Andy, you had mentioned at that point, if you take all three of those components, your PEEP and your volume and your plateau, the result of the application of your PEEP and your tidal volume, it isn't each one of them individually that hurts you, right? It isn't the volume by itself, it isn't the PEEP by itself, and it isn't the plateau by itself. It's the combination of all three of them that then therefore determine your driving pressure, which is going to hurt you and injure you. And you want to shoot for that goal less than 14 to 15 that we had talked about. But I think what you're left with, and what I would counter is, I think you have two decisions. It is either that driving pressure is either achieved either from, because if you're thinking about it, the difference between the plateau at the top of lung volume and the PEEP at the bottom of a lung volume, you can squeeze it either from the top or the bottom, if you think about it in that way. And so I think the easiest way is to just go get the volume and bring it down, right? Go below 6 cc's. I know that we don't get into the data and we don't show papers, but there's a really great paper in the Blue Journal by Gallagher and those guys and it has the posterior probability is the big wording that they use, but it's telling you what they're getting to is when is it appropriate to be decreasing volume and when it actually matters, right? Because in some patients, it has actually no therapeutic or benefit on the outcome by decreasing the volume. Your best strategy is actually to address the PEEP in some patients. And it's based on a normalized elastance. And it sounds really complicated, but it's actually pretty easy to get to the answer of, should I be decreasing the volume in this patient? And you're talking about individualized care at that point. The second strategy would be to either increase the PEEP from the bottom, both ways. You're squeezing the driving pressure. And you have to ask the same question in that patient. Is it appropriate to increase the PEEP in this patient in the same way you asked? Is it appropriate to decrease the volume? And then you're talking about recruitability. All right. If you increase the PEEP, you should expect the lung to recruit and the plateau to remain relatively the same or lower, and the driving pressure gets smaller. And so I think when you start to talk about driving pressure, you can talk about it at a 30,000 foot view, but I think it really then starts to get super individualized, because some people benefit from a drop in volume and some people benefit from an increase in PEEP outside of that asynchrony.
Good time. I'm going to try to keep up with these questions, and so I'm going to bring this for Dominic. Had a good question.
Yeah, and I apologize, Keith. I probably could have explained that a little bit better than just leaving it at no longer recruiting. A couple of people have attempted to type an answer in the chat, but I'll just address this. So typically, and how I train my staff, this is sort of the nuts and bolts way to do it. There's a lot of ways to figure this out. You can use esophageal manometry. You can use EIT. Somebody mentioned in the chat, if you have that technology available. If you don't, though, there's a kind of a down and dirty way to do this, and Eric kind of alluded to it. When you're turning your PEEP up, especially in the early phase of this disease, you should have some of this collapsed lung that Keith showed you in the CT and in the chest x-ray. Some of that collapsed lung may be recruitable if we add some pressure to the alveoli that we have that are functional and transmit some of that pressure into the other ones and recruit them. And so if we're able to do that, then as Eric mentioned, I'm going to turn my PEEP up by, say, 2 centimeters of water pressure, and then I'm going to see the plateau not change, which would then decrease my driving pressure. And as I'm able to continue to do that, and if you think about this on the pressure volume curve, you're thinking of your lower inflection point. I'm below that until I get to a point where I go up by 2 on my PEEP and my plateau goes up by that same 2 centimeters of water pressure. That puts me in call it the fat part of the curve. And then if I start to over distend, I get past the upper inflection point, right? I turn it up by 2 and my plateau goes up by more than 2. So where I want to be is above the lower inflection point. So I want to keep turning it up as long as I'm going up less on my plateau than what I turned my PEEP up. And then that's how I know that I've reached optimal recruitment, because now when I turn my PEEP up, it goes up by the same amount now. So I'm not gaining anything on my compliance. It's staying the same. The distance between my plateau and my PEEP is staying the same. Once I reach that point, I'm no longer going to get value from increasing my PEEP. Now my option to again, go back to something Eric said, to shrink these, now my option is to bring the top down to get me the rest of the way home. But because there's so many mechanisms, and I know a few months ago we talked about ventilator-induced lung injury, and Eric mentioned that none of these components by itself causes the majority of the lung damage. It's all of them together, which is why driving pressure becomes the metric we look at. But I could cause damage with a tidal volume that's set inappropriately, which would be volume trauma, a PEEP that's set inappropriately, which would be atelect trauma, or what some of the literature refers to as RACE, repetitive alveolar collapse and expansion. And then I can cause biotrauma because of the inflammatory mediators that are caused by my inappropriate vent management. So that's why the driving pressure is a nice metric to look at, because it pulls sort of all that stuff together and helps me understand that I'm managing all of these things as appropriately as I can. And happy to hear if anybody wants to expand on that.
I would just say if anybody wants to look at the popular driving pressure paper, they sort of stipulate that, hey, you know what, if you increase your PEEP and the driving pressure goes down, your outcomes will probably be better. If you increase the PEEP and your driving pressure stays the same, then you probably didn't affect outcomes. And then if you increase your PEEP but your driving pressure goes up, then you probably negatively influenced your outcomes. That's sort of a super, baseline way of describing that. Mm-hmm. Anybody have anything else to talk about? I think that we're sort of getting ahead of ourselves. I don't know. So what I consider basic ventilator management may have changed over the years. I think that I think since we're on the topic of basic ventilator management, let's say we had we had a discussion on ARC Connect recently about a patient that was received in a tertiary center from an outlier, a non-tertiary medical center that maybe didn't get optimal care and then sort of was late in fibrotic stages and maybe not much that can be done outside of transplant and maybe ECMO, which was not offered. If you guys were to, and then I'm going to get to these other questions, but if you guys were to say, hey, this is what every team and every hospital on the planet should be able to do for a sick ARDS patient, whether or not they wanted to receive this patient or not. Let's say you're in a small community hospital and you never see these kinds of patients, but boom, all of a sudden you have a really sick, severe ARDS patient. What can you tell people that may practice at these hospitals that are the most important things to do for these patients? Eric, can you start out?
Yeah, I see. I kind of popped into those comments. I didn't have them up. And there was this idea of measuring patients. Yeah, we measure them. I wouldn't trust anything that comes in on their ID. I mean, I'm 6'1" on my ID, 5'4" in real life with hair. All right. Geez.
Last time you had hair, Kreiner.
Yeah, you got to measure them. And
Easy,
I mean,
lamb.
no matter, yeah, right. No matter, I think no matter how much you try to escape it, we have a tendency that patient with a BMI of 45 gets a bigger volume than the one that isn't, right? It is your tendency to do that regardless of their height. I think we also fall into the trap of female patients. We overdose female patients. I think if you look at that, they have to be in order to get within 6 cc's or 6 to 8 cc's, they got to be pretty tall to receive a 450 volume and be within a range of that. Like it's remarkably lower if you look at the height to ideal body weight in females, right? And so what I'm saying is that you got to measure them and you got to find out the ideal body weight. And so if you're going to check any box in the basic section, make sure you have an accurate ideal body weight according to an accurately measured height, and then get yourself to 6 cc's. And I think you'll quite often be surprised at what that is based on these patients' height. That would be box number 1, right? And then someone else can take the next ones in the basic one.
I'll jump in and I'm going to tag onto it. John's going to probably agree too. He and I have the luxury of going to these used to, for me, have the luxury of going to these outlying facilities and picking these patients up. And you see a lot of variances in practice for some of these places that aren't part of a larger health system. Ideal body weight's a big one. And if you don't start there, you're not being lung protective. That is your linchpin that you've got to go with. I completely agree with Eric to go with that. Some of your manufacturers now of beds are actually putting a measuring tape on the side rails. So if you can get your feet lined up, and there's no excuse for you not to have a height. On the flight side, doing scene calls, we didn't carry tape measures, but I did measure the stretcher mattress, and it was 6 foot tall. So I had a quick and easy down and dirty to get a height in and be more safe in some of those type things that happen when they show up. So starting there, the cc's per kilo is going to be a big one. ARDS paper and driving pressure, I think, are probably the two other biggest things for these smaller facilities or tertiary feeder hospitals that they need to get on top of and go by. PEEP's going to be a big one because we see a lot of ER docs or intensivists that haven't spent a lot of time and are really busy, active ICU and have done a lot, and they are PEEP phobic. They really are. You'll spend every paper you've got, every ounce of time you've got, and you won't get them over 5 or 8. They will not budge. And as we all know, if we had to set one thing besides ideal body weight, as Andy pointed on, PEEP's the next one. Because if you don't get it right, everything else is not going to play fair.
Okay, I'll jump in, but I got to tell everybody that yes, outside my window, I have 2 hangars being built. So construction out the yin yang. My popcorn is actually a big tractor that's moving dirt around, which is kind of the best job in the world. You just move dirt all day. And then I have jets taking off the runway. So forgive me for all this background noise. But what I was going to add to this and to go what Eric said and Joe just said is setting your vent up properly. As a community, are we failing our patients and not explaining driving pressure and not understanding driving pressure? And while it doesn't by itself as a surrogate, that's not going to cause all the harm, as Andy and Erica pointed out. But with the tidal volume, let's say your pressure is 28 and your plateau is 26 and your PEEP's at 5. Well, your driving pressure is 21. That's above 16 or above 15 the last time I checked. So are we not doing any favors to our patients by explaining to these physicians that Joe just talked about, here are these interns, that we're not telling them about driving pressure, that we can't explain it properly. There have been papers done by a group in Iowa, Nick Moore's group, that looked at tidal volumes and transport, and those tidal volumes translated into the same tidal volumes at a receiving facility. Michael Allison from University of Maryland, they showed the same thing. When your patient goes to the ICU from the ER and their tidal volumes are set inappropriately by 1.5 mLs per kg, so 9.5 mLs per kg ideal body weight, developed ARDS more often. So it's us. We are still to look at in the mirror and say, am I doing this appropriately? And am I serving my patient in the best interest? And I think that's very elementary. When you look at, being in critical care and being in these ICUs, we should understand these things and be able to translate that to other practitioners, so we're all on the same page.
I'll add one more thing to the basic, and this is, again, somebody mentioned PEEP phobia. I think it was Joe. PEEP phobia is a real thing, but so is they've got to have a normal ABG. And I think that is a huge thing in basic ARDS management, is you don't need a 7.40 pH. And in fact, you're probably doing harm if you're targeting a 7.40 pH. The ARDSNet trial specifically said your goal should be 7.30 and above. Right. So, and I will tell you, in my ICU, we're happy with 7.27, 7.28. If we can keep the vent settings to a more minimal level. And so I think getting in the mindset that I'm not chasing a normal gas. And in fact, it's probably harmful if I do chase a normal gas. And then again, to Hollywood's point, explaining in a politically correct manner and in a clinically relevant manner to the team that you're working with, here's why I'm fine with this 7.27 ABG on these vent settings at this time, with the understanding that maybe we change something later. But I think, the more you chase a normal ABG, the more you probably put vent settings in that are less than ideal for that patient during that part of their disease process. And then, you start getting yourself behind the 8 ball.
And maybe I'm getting a little ahead of the game here when we talk about conventional things, but I would love to hear Eric's take, whether now or in a few minutes, about mechanical power. And when we step into these facilities or these outside facilities of 100 beds, and we're going to get a patient who's going to come up for ECMO, or they're chasing the perfect blood gas, as Andy had pointed out. My pH was 7.28, so the respiratory rate, I turned it up to 35, and my head wants to explode, because how much are we doing for that patient when you have that kind of power being introduced into the lung? I can't imagine that can be helpful.
And for lessons learned from old papers, remember the 2000 ARDSNet paper. The patients that oxygenated better in days 133 did worse. They did worse. The patients in the poor oxygenating group in days 1, 2, 3 were where your survivors mostly came from.
That's 100% right, Joe.
Yeah.
The ones on the harmful tidal volumes actually did better in the short term before they crumped, right?
They did better.
Yeah, I mean, there's even more data been published. Lots more data since then been published about how targeted oxygenation values probably don't improve outcomes. Let's hold on to the mechanical power and the things that we probably consider advanced areas of understanding here. But Hannah, one of the best ICU nurses I know, is asking, what do you do if you have a patient with below the knee amputation on both sides? Do you use the height that's in the chart previous to all of this, or do you use some other method? Anybody want to speak to the fingertip to fingertip method or anything else?
If they have the other leg, you can measure that one and get their height. If they're both gone, then the fingertip to fingertip is an acceptable method, provided they have those two.
Yeah, I went through a spell there where I was doing that method. Anybody else use that?
It's fairly close.
Yeah.
You have nothing to go with.
And I'll put a link to a reference to that in the chat box here momentarily. What else?
So what did we come out with? You got to get the volume right based on that particular patient. So you should probably make sure that you get an idea of body weight out of them. You should probably use not a lower level of PEEP, but more of a moderate level of PEEP, right? Not being PEEP phobic. So what that means maybe is at least 10, right? Somewhere in that ballpark if we're just spitballing basic management. At least, right, at that point. Not 5, not 8, but at least in there. And you should target a driving pressure that would be lower than 15, which makes your measuring a plateau of utmost importance, right? You have to perform the inspiratory hold in these patients and get a end inspiratory alveolar pressure so that you understand the effects of the settings that you have that you've designed, essentially. You're the architect of a breath that is hopefully non-injurious. And how is it designed by you to be non-injurious? Appropriate PEEP, appropriate volume that results in an appropriately low plateau pressure. All of that equates to a driving pressure of less than 14, right? And so I think that's basic management as you come out of there, right?
That's a great point, Eric, and that the lung safe trial that Keith alluded to earlier. They actually one of the side pieces that they found there was, and I'm paraphrasing here. I don't remember the exact number, Keith. Maybe you do, but it was less
than 40.
Yeah, less than 40%. We're getting we're actually measuring plateau pressures on these patients that had known ARDS. Mm-hmm. So Joe mentioned earlier that there's so many places that don't do the basic, like the basic of the basic things yet, like set tidal volumes according to Dale body weight and measure a plateau pressure with every assessment and every ventilator change to ensure that change was a safe change. I think that's obviously, if we're going to start somewhere, let's start there and then move on to using that information to keep the driving pressure safe, to do these other things that we're mentioning. But none of that matters if you're not putting the right tidal volume in and measuring a plateau pressure when you are assessing the patient with every change and with every assessment.
The architect of a breath. I absolutely love that, Kreiner. So that was brilliant. Keith, you had pointed out on Connect recently, everybody that you assessed always had a respiratory rate of 18. It's like the same way with the ventilator, that everybody has a plateau pressure of 28 or a driving pressure of 14 or 15. Are we really doing that? And again, as a community, are we letting our patients down by not doing that with every patient ventilator assessment? Or even more so, if you're making changes to try and find that optimal breath or that optimal PEEP setting. Again, I mean, the literature is out there. And again, I think you guys had talked about, I don't know if that was the paper by the folks in Hopkins that talked about when they self-reported that, folks in their ICUs were using lung protective strategies about 40% of the time. And you're talking about one of the premier institutions in this country being Hopkins. So, and that was 10 years ago. So have we gotten better? Our mortality is still 40%. And we have, we're paying attention to the Proceva trial. So we're proning our patients. Obviously, COVID proved a lot with that. We have ECMO. We have lung protective strategies to go with ECMO, like in the late 70s when Zappel did his study and showed that most of those patients died because of, lung issues or lung damage, probably from bad ventilator settings. So we have a better understanding now of vent settings and obviously some pretty invasive, cardiac assist devices or lung assist devices. And yet here we sit at 40%.
to dive into, I got to stay on the surface here because this can dive into another 2-hour topic altogether.
I'm just teeing it up for part 3.
This could be part whatever. Electronic medical record on the surface. If you're collecting vent data, that might be somewhere to start getting hopefully some more accurate data. I know there's caveats there with garbage in, garbage out as well. But having those numbers to blow over can help to maybe identify something early or, catch these things at a better point. And not to hop on a soapbox. I kind of do this with every ARDS talk or lung protective talk that I do. Before we dive into all this stuff, make sure your patient's resuscitated. Make sure your patient is resuscitated. Make sure they have adequate hemodynamics, because if they don't, then we can't do all these crazy things that we're really wanting to do. And ultimately cardiac output, O2 delivery, CO2 delivery to the lungs, all that takes a hit and they ain't going to get any better.
One other thing I think it's important to mention with all this stuff that we're talking about and, doing a proper assessment and putting in the proper settings, understand too that, let's say we start this journey on day 1, right, of their decline into this disease process. ARDS is a dynamic disease process, right? It's going to get worse in certain areas of the lung. Your inflection points are going to move. So what might be optimal PEEP on day 1 may not be optimal PEEP, and your driving pressure may change on day 3 and then again on day 5. So that's why I say, doing these assessments, making sure you're still on a safe tidal volume, making sure your driving pressure is still safe every few hours, rechecking the plateau pressure, because again, it might have been fine at 7 o'clock in the morning, and then by 3 o'clock in the afternoon, you may have seen something change with respect to this disease process. So, making sure that not just checking a plateau, but continually assessing these parameters and assessing these settings to make sure that they are optimal on day 3 if they were on day 1, because things may have changed and probably will have changed in some way.
Some places
So
check
that may go hand in hand.
Yeah.
That may go hand in hand with Joey's resuscitation efforts, right? Liters and liters of crystalloid or blood product may change or, change. So that's very complex. But for the very, very, very basic tidal volumes, plateau pressure, driving pressure, these are all things that that folks can, anybody can sort of monitor and target and customize. Another one of Kreiner's terms is dosing the ventilator to the patient. Ever since I heard him say that for the first time, I use that all the time. So customizing, what was the term again?
Architecture, the architect of the breath. Yeah.
Yes. Architect of the breath, and dosing of the ventilator. I want to make sure. So we are for sure going to do a part 3. I want to make sure that we can get this in 3 different parts. So I'm going to cover, I want to bring to, somebody had a really good question. So anybody want to jump on this one right here?
I can't see it, unfortunately.
Can you please comment about the safe flow range in case of constant flow ventilation?
I think that comes into play when you're looking at spontaneous breathing and PCLE, to be honest, to not dive onto an older topic. But if your patient's sedated, heavily controlled, and they're not really interacting with the vent.
And isn't flow rate part of the mechanical power?
It can be, but if you're giving X volume over X amount of time, then flow is going to be a variable of that, So we're kind of, in some cases, you may be directly setting it or indirectly setting it, but if you're following cc per kilo and have your IDE where it needs to be, then flow is going to be X of the equation. What do you think about that, Kreiner?
So I would say, first and foremost, I think I'm more worried about alveolar pressure than airway pressure, right? That's like just coming out of the gate. I mean, so if you're going to talk about a safe flow range, the implication of that would be your peak airway pressure or your actual airway pressure measure, right? And just out of the gate, I'm more worried about your alveolar or your plateau pressure than your peak, right? But don't talk to me about your peak before we get everything else satisfied. And so you're often pushed into a corner if you're going to drive a rate really high and try not to introduce this idea of air trapping and auto PEEP, that you're going to have to drive a pretty significant flow rate to maintain, adequate emptying on exhalation. And then you often get boxed into this corner where your peaks are high, but your plateau is acceptable. And so talking about a safe range, out of the gate, I'm like, if your plateau is okay, then I would be all right. If everything is all good, then you can kind of start to ask, well, can I lower my flow without causing air trapping on the back end at the end of exhalation to lower the peak in that case, right? And so I don't know that you get to a safe range. You're right. The flow is introducing the mechanical power in the form of peak pressure, right? And it is impacted in that way. I think it all just comes as a result of what you're trying to do at a really high rate, right? And when you get backed into that corner. So if you can be acceptable or accepting of a lower pH, therefore maintaining a lower respiratory rate, therefore maintaining a lower flow, and then your peak comes down. I think that's your best way all the way through that. And people get into that snafu of, well, I need a higher pH, therefore I need a higher rate, therefore I need a higher inspiratory flow, and now my peak is really high. And so I think that's a tough question. I don't know that there's one absolute acceptable safe flow that you can kind of arrive to. But in the end, I think I do back away and always say, well, actually, I'm just more worried about your plateau instead of your peak, because it's lost in the upper airway as opposed to being affected in the alveolar
Agreed.
area, right?
And if you're targeting plat and driving pressure, you're ultimately probably decreasing your tidal volume.
Mm-hmm.
And if you're doing that, you're decreasing flow. So,
yeah.
Agreed.
What do you guys think related to flow? What do you guys think about having a lower flow to get you to a little bit longer I time for gas exchange and oxygen delivery?
I think you always use the lowest amount of flow that you can get away with without introducing the idea of air trapping, right? And so you'll, if you were going to design everything, you would push the envelope, just knowing full well of the implications of you backing off on flow. Backing off on flow lengthens I time, shortens expiratory time, and now your total PEEP is something that you have not accounted for, right? And so, lengthening that as much as you possibly can allows you a longer component of inspiration, which allows more complete and better distributed filling, right? Because it plays off of the inspiratory time constant.
Bingo.
Right. So
how do y'all feel about Nick's question in the chat about discontinuation of care relating to the lack of a change in the mortality rate?
Yes, so Nick says, how much of the lack of change in mortality is due to a change in medical ethics, which allow for compassionate endpoints of care, et cetera, which are different from the 70s, 80s practice of medicine where things were all or none? I mean, I got to say that there's, so Nick is an oldie but goodie himself, and this is an oldie but goodie topic.
Well, let me. Here's my caveat about a lot of what we see about the lack of change in mortality, and this is me pontificating. And I will just go straight to all of the PEEP trials, all of the classic PEEP trials, right? Which would be LOVE, Alveoli, Express, all of these, right? Which has shown us that there's no mortality benefit as you increase to higher levels of PEEP. You can then talk about the ART, which was, actually showed a worse mortality, right? But I think what we have failed to do in all of these mechanical ventilation trials, which we're sitting here talking about in some way, shape, or form, is that we have lumped all of these patients with the single stratification of oxygenation, right? We've said patients will be included into this trial with a PF ratio of less than 150. That's our inclusion criteria. And when you then say, okay, we're going to use high PEEP versus low PEEP, and we're going to randomize into two different groups. What you haven't asked is the patient recruitable or not, right? And which we're saying on, and so what we're talking all around is the individuality of all of these patients really makes a difference in the end, right? And so some patients are recruitable when you increase the PEEP. We talked about that the plateau pressure should go down, or at least remain the same and remain linear, so that you are on that part of the pressure volume curve. That's personalization as you're going to that. You're not just increasing PEEP and not paying attention to it, right? But all of these kind of particular trials lump everybody as responders, thinking that they're responders, into these groups, right? And so I'll just say, let's say that you had a patient with an intrapulmonary disease process causing their ARDS. Therefore, they tend not to be as recruitable as somebody that had a septic cause of an ARDS. It tend to be a little bit more recruitable. And let's say that you had the pneumonia patient, intrapulmonary, in a high PEEP group. Well, when you increase that patient with really high levels of PEEP and they don't recruit, you're just going to be hurting those patients at that particular point, and you're going to have a confounder in your outcome, right? And so we tend to lump all of these, in all of these trials, without any changes in mortality, we lump everybody together and give them the same recipe of treatment, right, across the board, and have yet to test. This is forthcoming, right? All of these emerging trials are forthcoming in terms of the individualization of care, right? I think all of those trials are recruiting, all these multi-center trials that are doing recruitability of the lung prior to applying higher levels of PEEP. Because if you're not recruitable, we shouldn't be using high levels of PEEP anyway. We're gonna just hurt you, and you're gonna kind of ruin the result, right? And so that's when you're talking about this change in mortality, and there's not a change in mortality within the literature. I think the frustrating part is we've come to this conclusion, it seems like, that we can start out with garden variety settings, but we eventually, when patients don't respond to them, we eventually have to individualize, right? And we have to then make it so that we apply the ventilator personally in these particular patients. But yet all of our literature is not in the individualized basis. We've lumped them all together. And so as I think about it, it's kind of not surprising that we don't have a really good result or signal, because we've treated everybody the exact same way when we are talking out of the other side of our mouth, outside of the literature, that saying, oh, we shouldn't do that, And so I don't know, Nikki. I mean, like, that's what I would say to that. Like, that's why we haven't gotten anywhere. I feel like we don't know whether to use high PEEP or low PEEP, because we treat everybody the same with high PEEP or low PEEP, when we know that they're not the same. So I think that answer is yet to yield, Nick.
And so now that we know, we're going to be doing a part 3, and we're going to save the advanced interventions like EIT, all the things that are on that slide. Let's go ahead and just Steve Schramm had one question here that I think that we should try to answer. The old paralyzed neuromuscular blockade or no neuromuscular blockade. Someone said if their compliance is in the 20s, we should paralyze the patient to prevent PCILI. Any thoughts on that? I know we did a whole panel discussion on PCILI all by itself, but anybody want to just address this real quick?
I think that feeds right back into what Eric just said. Paralyzing to prevent lung injury, sure, you're going to take the rate away, but probably your next goal, you're probably going to start increasing PEEP. And the first question is this a primary, is this a secondary ARDS patient in front of us? Are they going to recruit or not? Is it going to make a difference if you do that or not? That's probably the first question I would ask. The second piece is going to be, again, are you using ideal body weight? What's their plat? What's their driving pressure? All those other pieces that we've talked about is going to play into this as well. Paralytics might be an avenue if we've tried everything else to get us to those points we may need to be, but in and of itself, it's not going to prevent lung injury by itself. You might give depending on where the patient is in the spectrum, if they haven't been resuscitated, you might cause yourself more problems. You may have a code in front of you if you go to that route.
I think on a basic level, and I know we're running up against time here, but I think on a basic level, and I think, Keith, this should be something that we circle back to with the advanced as we talk about transpulmonary pressures and sort of the effect that those have. But just relating this to the basic level, I think when you look at deep sedation and paralysis and the side effects that come with that, I think what you think about more so than lung compliance is vent synchrony, oxygenation, what you're having to do with the ventilator, and are you able to reach your ventilator goals with respect to driving pressure, with respect to PEEP optimization, without it. And if not, then you should consider using it. I don't think the compliance in and of itself should be a deciding factor in adding paralysis or deep sedation or both.
Okay.
Yeah, I think that in the setting, so it's really an interesting topic, and we're going to save it. We're going to start back in part 3 with this topic. But in the setting of trying to prevent patients' self-inflicted lung injury, I think neuromuscular blockade falls into that category of, yes, the majority of the time it improves gas exchange, like proning does. But is the real advantage to paralyzing somebody sort of mitigating that transpulmonary pressure that's being caused by the patient themselves instead of just the ventilator? But I think we should pick up where we ended there next time. So that all being said, on this slide that you should be able to see right now, my personal email address, so you can reach out to me for anything. Our YouTube channel, which you can go to see archived panel discussions, which there are many. We've been actually doing this now for over a year. So we've got a bunch of these things out there recorded. And then the last link there is to our website, where you can find other links to our YouTube channel, etc. So I want to thank everybody for joining today. I want to thank the panelists. I want to thank everybody who signed on to listen and to contribute via the chat there. And pretty soon this will be available on our YouTube channel. And of course, we encourage you to share it. We'll share it on our LinkedIn pages and our personal pages as well. So I want to thank everybody again, and I appreciate your participation, and we hope to see you in part 3. We'll get that date out as soon as we possibly can.